A 50-year-old female presented with nausea and vomiting due to gastric outlet obstruction. An endoscopic examination was requested for further management. A lesion was visualized in the duodenal bulb. What is the diagnosis? A. Gastrointestinal stromal tumor. B. Spindle cell tumor. C. Lipoma. D. Duplication cyst. An EUS examination was performed which showed a 5 by 5 cm anechoic lesion. What is the diagnosis? A. Pancreatic pseudocyst. B. Duplication cyst. C. Malignant degeneration of a cystic neoplasm. The answer is B. Duplication cyst. What is the next step in management? A. EUS-guided transmural drainage. B. Aspiration of the cyst using a 19-gauge needle. C. ND tube placement for enteral feeding. D. Surgical management. The answer is D. Surgical management. Duodenum is the site of origin of 12% of all duplication cysts. Risk of malignant degeneration is less than 5%. Surgical enucleation is the best definitive treatment. If the cyst is adjacent to the major papilla, a Whipple procedure may be required. In high-risk surgical patients, in such cases, endoscopic drainage may be an option, but the data are very limited. A 62-year-old male presented for EUS examination of a rectal mass, discovered incidentally during a screening colonoscopy. On EUS examination, an anechoic lesion was seen in the rectum. What is the diagnosis? A. Colon adenocarcinoma. B. Hindgut duplication cyst. C. Gastrointestinal stromal tumor. D. Lipoma. E. Leiomyoma. The answer is B. Hindgut duplication cyst. What is the next step in management? A. EUS examination every year. B. Surgical excision. C. EUS-guided FNA with rapid on-site evaluation. D. No further follow-up or treatment needed as the patient is asymptomatic. The answer is B. Surgical excision, due to the risk of malignant transformation. A 70-year-old female was referred for further evaluation of incidental asymptomatic pancreatic cysts on CT abdomen. On EUS examination, multiple pancreatic cysts were identified throughout the pancreas. Based on EUS, what is the diagnosis? A. Intrapancreatic lymph nodes. B. Side branch IPMN. C. Metastatic cancer. D. Pancreatic pseudocysts. What is the next step? A. Repeat EUS in 1 year. B. Referral to surgery. C. EUS-guided final aspiration. The answer is C. EUS-guided final aspiration. Final aspiration of one of the pancreatic cysts was performed. What is the next step in management? A. Surgical referral. B. Oncology referral. C. Repeat EUS FNA with dedicated pass for cell block. The answer is C. Repeat EUS FNA with dedicated pass for cell block. What is the diagnosis? A. Pancreatic adenocarcinoma. B. Chronic pancreatitis. C. Metastatic cancer. D. Mucin with atypical cells. The answer is C. Metastatic cancer. Subsequent immunostaining on cell block was positive for CD10. consistent with metastatic renal cell carcinoma. Multiple solid lesions in the pancreas suggest metastatic disease. EUS-guided FNA establishes a definitive diagnosis at ROSE. Dedicated passes must, however, also be performed for cell block to facilitate ancillary studies. Renal cell cancer, breast cancer, melanoma, small bowel cancer, and lung cancers can all metastasize to the pancreas. A 70-year-old female presented with a 2-month history of epigastric pain and 10-pound weight loss. A pancreatic cyst was seen in the tail of the pancreas on CT. She was referred for an EUS examination. In the tail of the pancreas, an anechoic lesion measuring 3.5 by 2 centimeters with a hypochoric component was visualized. Based on EUS imaging, what is the diagnosis? A. Serous adenoma. B. Pancreatic adenocarcinoma. C. Side branch IPMN. D. Mucinous cystic neoplasm. What is the next step in management? A. CT-guided biopsy. B. EUS-guided FNA or FNB. C. Surgical resection. The answer is B. EUS-guided FNA or FNB. EUS-guided fine needle biopsy of the lesion was performed using the acquired needle. The fanning technique was used to sample various areas of the mass. Rapid on-site evaluation of the obtained sample was performed. What is the diagnosis? A. IPMN. B. Mucinous cystic neoplasm. C. Serous adenoma. D. Pancreatic adenocarcinoma. E. Solid pseudopapillary neoplasm. The answer is D. Pancreatic adenocarcinoma. Cystic lesions in the pancreas with a mass component require sampling to exclude malignancy. While some EUS imaging characteristics may be suggestive of high-risk neoplasm, morphology alone has a diagnostic sensitivity of only 60 to 70%. All borderline surgical and inoperable candidates require sampling to guide management. All operable patients who are symptomatic must be referred for surgical consultation, irrespective of findings at EUS. An 80-year-old male with abdominal discomfort underwent an EUS examination for further evaluation. On EUS, a mass was seen adjacent to the liver. What is the diagnosis? A. Gallbladder cancer. B. Retroperitoneal cyst. C. Malignant melanoma. D. Colon cancer. E. Lymphoma. What is the next step? A. CT-guided biopsy. B. EUS-guided FNA or FNB. C. Surgical exploration. The answer is B. EUS-guided FNA or FNB. EUS-guided fine needle biopsy of the mass was performed via the duodenum, using the novel Acquire FNB needle. What is the diagnosis? A. Gallbladder cancer. B. Retroperitoneal cyst. C. Malignant melanoma. D. Colon cancer. E. Lymphoma. In order to delineate the lesion further, water was injected into the bowel loop using a 19-gauge needle. This resulted in distension of the bowel loop. What is the next step in diagnosis? A. Colonoscopy. B. PET scan. C. Double balloon enteroscopy. Methylene blue was then injected with the acquired needle into the mass for easy identification of the mass during colonoscopy. A colonoscopy was performed following a fleet enema. Methylene blue was seen in the right colon from the previous injection. A large colonic mass was then seen, coinciding with the mass seen on EUS. The mass was biopsied. which was diagnostic for colonic adenocarcinoma. Installation of water helps in identifying the origin of lesions. Fine needle biopsy specimens can be evaluated by rows. Dedicated passes must always be performed for ancillary studies. Although rare, there is a possibility of tumour seeding. A 65-year-old male presented with a 2-week history of abdominal pain and fever. CT showed a pancreatic lesion. EUS was performed for further evaluation. A large lesion was seen in the head and onset process of the pancreas. What is the diagnosis? A. Pancreatic fluid collection. B. Mucin cystic neoplasm. C. Side branch IPMN. D. Pancreatic cancer. What is the next step in management? A. EUS-guided transmural drainage. B. Conservative management with enteral feeding and antibiotics. C. Surgical drainage. D. EUS-guided fine needle aspiration. The answer is B. Conservative management with enteral feeding and antibiotics. EUS showed a large walled-off necrosis containing solid debris with an immature wall as shown by the arrows, and hence not yet suitable for drainage. Drainage of a pancreatic fluid collection with an immature wall is associated with a high risk of perforation. Conservative management with pancreatic rest is therefore warranted until the wall has matured prior to attempted drainage. A 73-year-old male with a history of acute necrotizing pancreatitis was admitted with abdominal pain and fever. CT of the abdomen revealed a walled-off necrosis. On EUS examination, disconnected pancreatic duct was seen, which was characterized by identification of a well-defined fluid collection along the course of the main pancreatic duct, with the upstream pancreatic parenchyma and pancreatic duct terminating into the fluid collection. What is the next step in management? A. Standard EUS-guided drainage. B. Multigate technique of EUS-guided drainage using lumen-opposing metal stent. C. Multigate EUS-guided drainage with plastic stents. D. Multigate technique of EUS-guided drainage with lumen-opposing metal stent and plastic stents. E. Conservative management. The answer is D. Multigate technique of EUS-guided drainage with lumen-opposing metal stents and plastic stents. Due to the size of the walled-off necrosis, a decision was made to use the multi-gate technique with creation of 2 transmural tracts. Also, due to the presence of disconnected pancreatic duct syndrome, we decided to use 2 different stent types. In the first tract, a lumen-opposing metal stent with a larger stent diameter will be inserted to allow rapid drainage of the necrotic contents. In the second tract, plastic stents will be inserted, which can be left in situ indefinitely to drain the disconnected upstream pancreatic parenchyma. Insertion of a 15mm diameter dual-flanged lumen-opposing metal stent with an electrocautery-enhanced delivery system was first performed. The walled-off necrosis was accessed using the electrocautery-based catheter delivery system. After positioning the catheter within the walled-off necrosis, stent deployment hub was released to deploy the distal flange of the stent. This was followed by deployment of the proximal flange within the gastric lumen. The echoendoscope was passed more proximally into the gastric body for insertion of the plastic stents. The walled-off necrosis was first accessed using the 19-gauge needle, and a soft tip guide wire was inserted through the needle into the collection and allowed to coil several times. The transmural tract was then dilated using a graded tip catheter followed by a dilating balloon. 2 7 French 4 cm double pigtail stents were then inserted through the transmural tract. A CT performed at 72 hours post-procedure showed a significant decrease in the size of the walled-off necrosis with both the lumen-opposing metal stent and plastic stents in situ. At 4 weeks post-procedure, due to the presence of a disconnected pancreatic duct, only the lumen-opposing metal stent was removed, leaving the plastic stents in situ indefinitely in order to drain the disconnected upstream pancreatic parenchyma. Walled-off necrosis comprises 50% of all pancreatic fluid collections, and more than 60% of walled-off necrosis patients have disconnected pancreatic duct syndrome. Rates of pancreatic fluid collection recurrence in DPDS range from 20 to 45%. Indwelling stents drain the upstream gland and decrease PFC recurrence to less than 5%. Only plastic stents can be left in situ indefinitely and should be considered for placement in patients with DPDS.